Thanks, everyone. Welcome. Thank you for joining this evening. I'd like to acknowledge that we're holding and running this seminar on Ngunnawal country and pay my respects to the elders, the Ngunnawal people of these lands that we're meeting on, to the elders past and present, and also acknowledge any other Aboriginal and Torres Strait Islander people in the room today. I would also like to acknowledge the ongoing contribution to our community and also more specifically around end of life. Thank you everyone for joining. This is number 6 of a 7-part webinar series on palliative care or end of life in primary care in the ACT. We've had really good engagement for our previous sessions, and I hope this session you find as valuable as the other ones we've had. Tonight, you will have a chat box and a Q&A box. Please, any questions, can you pop in the Q&A box, please? You will be on mute, so just keep in mind that you need to write your questions down in the chat. Please feel free to introduce yourselves, what your role is and your profession is. Thank you. We also will be sending out a survey to you for you to complete. I know these are a bit tedious, but please consider completing this because this helps us understand what your learning needs are in the space that you are working. This will also be recorded, and I'm pleased to say that the whole webinar series will be up on our CHN YouTube channel. At the moment, we currently have 2 of the sessions, session 1 and 2, up on our YouTube channel. All participants that have been registered for these workshops will be sent a link to that, so you will be able to watch the recordings as needed. So welcome. Thank you. No more housekeeping from me at the moment. Please shout out via Q&A or the chat if you've got any questions or need any tech help. I'd like to thank Kunal for joining us tonight from CHN. He is our education lead, and he has done a great job in organising and supporting these workshops. I'd like to introduce our first speaker, which is Dr. Amanda Barry. Amanda has been a general practitioner since 2007 and is a GP, and since 2007 specialising in clinical forensic medicine since 2008 and working as an FMO at Canberra Hospital since 2010. She's currently staff specialist at the Canberra Forensic Medicine Service since 2021 and unit director since 2024. Amanda has a particular interest in death scene examination. So thank you, Amanda, for joining us. And Amanda will speak first and Dr. Lavinia will speak second. Thank you.
Fantastic. Thank you very much, Ros. Now, I'm just speaking to a computer screen, so I can't see anybody, so I'm sorry. It feels really quite odd. I really appreciate the invitation. It's a real privilege being able to speak to this topic, which I'm really fascinated in, and I hope to keep to the same level of the previous seminars, so no pressure. So a big thank you to CHN and a big thank you to Dr. Lavinia, who has agreed to assist me with this presentation. So a little bit more about my history. So I've come from a GP background with a particular interest in forensic medicine. So I've specialised in this area now for the last 4 years solely within that space. And I have a particular interest in death scene examination. So I've done additional training over in America, have done some basic and advanced medical legal death investigator training as well. So I don't mean to come across as being particularly unusual, but I do find this area quite fascinating. So in terms of what I'm going to be speaking to this evening, so I know that we all come from various backgrounds, but I just want to put a content warning up to say there will be some discussions around deaths, obviously, and there will be some images that I'll display to show some signs of death. So just want to give the team plenty of warning before we get into that. To break it up a bit, I do like to lighten the mood a bit. I'm an avid scuba diver, and I've been overseas recently, done some diving, and I got to see this fish, which is a mandarin fish, which I think is absolutely beautiful, really inspiring, and keeps me going in this line of work, I have to say, because it can get quite heavy at times. And then my favorite critters are these. They're called nudibranchs. So I find these creatures really fascinating. They're quite small, and it keeps me entertained. So I will be putting up some of these pictures throughout the talk just to break up the nature of the content. So in terms of some learning objectives that we've identified for this particular seminar, what we'd like to, I guess, impart on the team is an understanding of common misconceptions regarding death certification, to give you some assurances around how to best do that, and that you're not alone in feeling a little bit confused around that. I'm going to particularly focus on developing awareness of the death investigation process in the ACT in particular. Within that, I'm going to outline what the service does at the Canberra Hospital, and in particular the death scene examination side. So we're quite unusual in the ACT. We're the only unit of this kind in Australia. There's maybe only a handful of these units in the world that does this particular type of work on the ground. I'm going to outline some key concepts in the Coroner's Act, which is important to understand in the context of actually doing death certification. And then understanding the difference between death verification and death certification. So the ones that I've highlighted in blue, I'm going to focus on those. And then Lavinia is very kindly going to expound on how to complete the medical certificate cause of death. So I'm going to focus initially on some misconceptions that abound in the health professional space. So when I do go out on a scene, sometimes we do liaise with GPs to have a talk about what we've found on scene and what we think could have occurred to their patient. All too commonly, I hear these sorts of comments that the GPs are not sure of the potential cause of death and consequently aren't comfortable so enunciating that on a death certificate. Commonly, we hear, I only saw them once or twice, or they're a new patient. The doctors cannot be 100% certain of the cause of death, and also that the medical defence organisations have taught them that they need to be certain. And the death was not expected in the patient. Commonly we have a well 92-year-old and we're told by the GP, look, I didn't expect them to die. So I guess at some point we all do unfortunately have to face our mortality. I think 92 is a pretty good age, so I sort of question that belief around that it wasn't expected. 65-year-old with diabetes, heart disease on 4 antihypertensives, again, well controlled, but I just want to put it out there, was death really not expected with all of those comorbidities? Their lifespan is definitely going to be shortened. And again, a 75-year-old smoker with COPD on home oxygen. So I think these are really common examples of patients that we will go see in the community, and GPs just aren't comfortable to take that next step. And I think for these 3 cases in particular, assuming everything else is fine and nothing meets the Coroner's Act, I think writing a death certificate is probably not out of the bounds of expectations. So if people are not comfortable writing a death certificate, is there any fallout? And I think there can be, both for the system as well as the families involved. So there is, I think, a misunderstanding that a decedent will undergo a post-mortem examination and internal examination, and that the cause of death will absolutely be attributed. So this is not the case in all cases. So every week there are 2 meetings that occur between a forensic pathologist, my units, the coroner, and the coroner's team, which is a specialised police team. And at these meetings, we look at all the cases that come to the coroner, and decisions are made as to whether an internal exam is done or medical notes are reviewed. Sometimes post-mortem internals are not done. Medical notes are reviewed, which is something that GPs would also be doing in the community to ascertain potential cause of death. I think there is a delay in returning the loved one to the family. So in the case where people aren't comfortable or sort of not 100% certain, what happens to the decedent is they're taken into the care of the police. They go to the police mortuary, go through that police process. So that takes time, and understandably, the family can be quite concerned and distressed over that. And there's also the question of resource utilisation. So we have numerous people involved in this process. And whilst we don't mind, we're very happy to be involved. We certainly are a resource-heavy service. So now I'll just go to outline exactly what the service does for the community. So my team, we're the Clinical Forensic Medical Service. We're located at the Canberra Hospital, and we're on call 24 hours a day, 7 days a week, every day of the year for, I guess, a variety of different services for the community and for the police. We have a contract with the AFP, the CFAC contract. FAMSAC is our sexual assault service, so that's a health contract. And then we also do the Fitness to Drive clinic. So inherent in that, we go to court quite a lot in our line of work. Within the CFAC arm, this is the police service that we provide. We go to the death scene examinations at the request of police. And sometimes we do go to the postmortems to assist the forensic pathologist to explain any on-scene findings that were present, particularly if it was a homicide or suicide that needs further input. Unfortunately, we also go to postmortems to do sexual assault examinations at times. We can do forensic procedures. So not only do we see people who report assaults, we see people who are charged and swab for DNA. We do injury documentation at the request of police. We do traffic assessments where people are driving under the influence. We manage the watch house at the city police station. We do occupational exposures for the AFP, and we also do fitness for interview for people who are charged. So I'm just putting it in context in terms of what my team do under that police contract. Death scene examination is quite a big part of that service. So in terms of death scenes, it really is a collaborative effort. So this can occur in the community or in the hospital setting. It invariably involves police. And sometimes, depending on the scene, it can involve crime teams, the general duties police, and the coroner's team. There's also a specialised crime scene investigator team with the police that can come to the scenes with us. We have entomologists available, anthropologists and forensic odontologists when we need to identify people, and plus or minus a forensic pathologist involvement. Obviously, ACTAS can be involved at the scene. There's my unit, and then importantly, GPs can also be involved. The call-outs over the last financial year, so my team went to 336 deaths in the community. Of those, that was composed of 50 suicides, 23 were deemed suspicious, and we had crime scene attend. We had 6 paediatric deaths, and then 133 of those were dual attendants with crime scene investigators. So we do work quite closely with the police. So our purpose when we go to death scenes, the quintessential question for my team as forensic medical officers. So we work with police, we're consultants on the scene. We don't tell them what to do, we advise, is to determine if something is suspicious and could it be a crime scene. So as I say, we never tell police. We certainly say there are findings that can be incongruous, and we also opine as to potential cause of death. Inherent in that, the team are trained to do a top-to-toe examination. We do a scene review, so not just looking at the decedent, but looking at their home, the way they lived, medications, the fridge, all of that is taken into context. Any documents that may be present at home, often the discharge summaries that are laying around are really helpful. Collateral history, so we may speak to GPs, the family and first responders. We've just won a battle to actually access the DHR. There were consent issues around that, but we can access a digital health record now and put a lot of the patient history in context before we even get to the scene. And then we also rely on police information, so ask them about alerts, any domestic violence, or any spurious associations that could be concerning. So once we have examined a scene, we determine with the police if there are any concerning findings or if something could meet the Coroner's Act, which means we can't get a death certificate from the GP. And there have been cases where police have contacted the GP's been willing to write the death certificate, we've arrived and said, oh, upon examination, we think that that's not appropriate for various reasons. Part of our role also is to consider escalating our concerns, so we can advise whether forensics needs to be involved in the scene, whether crime and detectives should attend, involving our second on-call doctor, who is a senior doctor, as well as involving the coroner's team. So it's very much a collaborative effort in making sure that the community is protected. We also contemporaneously document the history, any scene findings, and correspond that to the coroner. And as I say, importantly, it is a huge team effort. So we also have forensic nurses that can attend the scenes with us to assist. We've got the police, William Coles, the funeral directors involved, and the GP. Importantly, part of our role is to make sure that the scene is preserved, so to advise police of what they can and can't touch and what needs to be captured in terms of DNA or forensic collection. Part of our role when we attend these scenes is scene safety, so we make sure our physical safety is paramount, making sure we have appropriate access, that we have parking. Do we need to have any physicality in actually getting to the decedent? We need to think about, could the potential perpetrator still be at scene? Make sure the family members are okay and that they're well cared for. We also need to think about our own possible exits at that scene in case things get a bit hairy. And then there are work health and safety concerns when we attend scenes in the community. The common ones are hoarders, if we're at a collision scene or a fatality on the road, and biohazard concerns with bodily fluids. We're also very mindful of potential scene contaminants. That includes things like first responders and police, the family, and making sure that we don't contribute to that contamination. So inherent within this, we have vicarious trauma concerns as well. So we're very mindful not only of our exposure, but others' exposure on the scene, including new police officers. So every 3 to 4 months, new police come on scene. We're just very aware of protecting them. Certainly seasoned officers talk about their PTSD bank, which I think is a really concerning comment to make. And sometimes we do have dark humour. It's never disrespectful, but it's often a coping mechanism that's employed. As I say, the family sometimes can be on scene. So there have been cases where the perpetrator is still present on scene, and that can be a real safety concern. Certainly just worrying about the contamination point of view with the family who still want to be around the loved one, still want to hold them, hug them. That can affect the findings of death. And also in speaking to the family, we just want to make sure that there's nothing that could be genetic, such as sudden cardiac death. And does a family member require assistance? So we're there to also provide that care if that's needed. And often fielding questions from the family. So things like time of death, the mode of death and cause of death. Was their loved one in pain? Could have more been done? And to reassure the family. Also, there are public health concerns that we address whilst we're on scene. So if there's any concerns around infectious disease like COVID, tuberculosis, those sorts of concerns, as well as any potential environmental dangers. And then also there have been cases where we have had to involve CYPS urgently to protect children who have been on scene. So when we attend death scenes, sometimes we do need to wear these suits. They're Tyvek suits with these filtered masks, gloves, boots, the works, just to protect ourselves. We certainly look at what ACTAS have done, the nature of the interventions, the risk of biohazards, if they have removed equipment, if that's going to obfuscate the findings of death. And it's a bit of an education process for police regarding misinformation from ACTAS sometimes. Certainly inserting thermometers and saying the decedent's 23 degrees. We need to know those things. So if we find any rectal concerns or any other findings, it may have been related to that. So I think in summary, our FMO, our forensic medical officer scene assessment, is very much a stepwise process. It's anamnestic, so that's referring to circumstantial evidence. So our doctors are trained to actually take all of the history first, to assess the surrounds first, and then to do the bodily exam at the very end. Collateral history is critical because obviously the patient can't talk to us. Ensuring police alerts are asked for and that our safety is preserved, reviewing the scene. And as I say, electrodes incredibly reassuring. So there are cases where we worry that a patient could still be alive. So knowing that they've been assessed and have electrodes in situ is incredibly reassuring. So again, just a bit of a content warning. There is going to be talk about some death findings and some pictures. So when we assess a decedent, there are findings of rigor mortis, lividity, so hypostasis, where the blood pools. And there is no hard and fast rule in this, but certainly there can be a somewhat predictable timeline in terms of when rigor develops, and that can go through various different stages, from being primary flaccidity, so the joints are really flaccid, they're then developing into rigor, it's maintained over a period of time, and then they go into a secondary flaccidity phase. Over that time period, lividity is also forming. So that's where the blood is pooling and can be very much positional. So the blood will pool over a period of time, become fixated within 6 to 12 hours, and then there's further breakdown. So what the team are trained to do is to try and marry up some of these signs within the context of what we're told, the environment, and the medical history, to give police some reassurance around potential time of death. So this is something from Knight's Pathology, which is our Bible. It's not a hard rule, it's very much rule of thumb. So certainly one of our first assessments is actually touching the decedent to see if they're warm or cold, both centrally and peripherally, to assess the degree of rigor. And then those hours in the right-hand column are very much a rough rule of thumb in terms of potential time of death. And it's when there's any discordancy in those findings that we raise concerns with police, particularly if the time frame they're being told doesn't meet the findings that we see during the examination. So in terms of additional findings, so there's an array of findings of death that we see, and again is very much dependent on environment, what the person was doing prior to death, if they were well, what medication they're on. There are so many variables to consider. And we often have the CSI effect where people expect us to come on scene and to be able to say this person died approximately 2.5 hours ago. So that is not reality. I can tell police if it happened within a day to 3 days. After that, the findings of death become extremely difficult to discern, and I can't give them any more rigid time frame than that. So there are 5 phases that we can see depending on the time that's being reported. So that fresh phase, that's the very first phase. And within an hour or so, we can start seeing some observable signs of death. Most commonly, there are eye changes, there are skin changes that start to form. It can be a bit of purge where the fluid from the respiratory and gastrointestinal tract, because gas is built up, can be seen. And certainly some greening in the right iliac fossa where the ileocecal area is, a lot of bacteria there. That's one of the first signs that we can commonly see within 18 hours. Once you get up to around 24 to 48, it goes into a more active phase where the decedent can bloat. It can become more an active decomp stage where we start to get a lot of skin slippage, caving in of tissue, and some certain odors that are forming. And then we can get into the advanced and dry manger stage, which can be days to weeks to years. And certainly we have seen cases where mummification has occurred, and in a hot Canberra summer, that can be a matter of weeks. So some of the earliest signs of death can be retinal trucking of blood. This is, I don't walk around with a thermoscope, but that's what's been reported. I've never seen it. And then, as I say, we've got lividity, rigidity of the muscles, putrefaction, and then the smells of death can also occur. And then we go into, as I say, we assess things like algor, which is the temperature of the body. We do not measure the temperature per se, just whether it's warm or cold to touch. Putrefaction is technically equal to the physical signs of decomposition. So that's some of the signs that I've mentioned. So skin slippage, the purge, the greening of the abdomen. So going into rigor mortis just a little bit. So why does this occur? So we need ATP to relax the muscles, and rigor is initiated after death once the level drops to about 85% of normal. So if someone has been running a marathon, they've used up a lot of their ATP, they will go into a firm rigor mortis a lot more quickly than someone who hasn't done that activity prior to death. And then there's different phases of rigidity. So it can be quite easy to break in that initial period. And then it can be quite firm within about 24 hours. It's very difficult to break the rigor. And thereafter, it's easy to break because the proteins in the muscles are starting to break down. There can be a progression of rigor mortis. So when we're on scene, we're assessing that. So I generally start at the jaw. That's commonly the most common sign, the first sign where the muscles will go into rigor. And then it will go into the face and neck and small joints because they're smaller muscular joints, and then to the bigger joints. And then that will reverse as we go into flaccidity. So then the smaller joints will break down again. So it's this cycle that we're actually assessing when we're doing the examination. As I've mentioned, there's lots of variables, too many to actually list, but some of the things that are common is the temperature. Environmental temperature has a huge effect on rigor formation. If someone's robust, it will take longer to go into rigor mortis. And if there is a small muscle mass, so a child or a smaller person, they will go into rigor mortis quickly, and then it will break down very quickly as well. And various drugs can play into that as well. Livor mortis, that's the blood staining that I've spoken about. It's the gravitational pooling of the blood, and it will go to the dependent areas of the body. This is what livor mortis can look like. So it can be commonly, if you're not used to seeing it, you may think it's a big bruise, but it's very different to bruising. And it will blanch within the first 6 to 12 hours. After that period of time, it then starts to fixate. So you can appreciate that within that sort of 12-hour period, as a rough rule of thumb, if the body has been moved post-mortem, that blood will move with that position. There have been cases where people have been found and lividity, like a lady was found on face down, lividity was found on her back. So we knew that that person had been moved post-mortem. This is what a death examination pro forma looks like. So for a very straightforward death, this is a form that we will use. We'll note all of our findings, and then that gets forwarded to the coroner. For a complicated scene, there is a 10-page document that we use. It goes into a lot more detail. And then for a pediatric scene, that's a 20-page document. So the degree of examination in the community depends on the nature of the death.
Here's what I found.
So key points I would like to impart on the team based on what my team does for the community. So death examination within our space, it's very methodical. It is quite a complicated process, and it is a subspecialty of clinical forensic medicine. The postmortem interval can be very difficult to give a definite answer for, and inherently we can't help beyond about 72 hours. And my team will complete a life extinct, not a death certificate. And the importance of the awareness of the Coroner's Act and practitioner obligations as well. And just to know, if we do call you, that we're there to support the process, and we're here to answer any questions that people may have. So just to highlight what the Coroner's Act is, so it's really important that you understand what you cannot sign a death certificate for. So I encourage people, I have this on my phone, I have it on a bit of paper, I don't have them memorized, but these are the stipulations whereby if this is suspected in your patient, you cannot issue a death certificate. So the ones to highlight in particular, and Lavinia will go into a bit more detail, if you haven't seen them within the preceding 6 months, obviously if there's anything suspicious, or if it was completely or partly attributable to an operational procedure. So those are the key ones to understand. So common examples of an accident where you shouldn't sign a death certificate: if you suspect a fall has occurred and that could have contributed to the death. Obviously, drowning. Had a patient who rode into a tree in the community. So they're ones you can't write a death certificate for. Dies unnaturally. A good example is an unexplained head injury that definitely needs further police investigation. And examples of cause of death being better ascertained: so unintentional overdose, a workplace incident, or medication error. So if you suspect any of those, then a death certificate cannot be issued. It's also important to be aware of the Births, Deaths and Marriages Registration Act of 1997. So doctors need to give notice of death within 48 hours after the death or of your knowledge of the death. If you were responsible for the deceased person's medical care immediately before death, and the important part here is or, so it's not an and, you examined the body of the deceased, so you can issue a death certificate without having examined the decedent in the ACT. It's only the ACT in Queensland where this is okay. Anywhere else in Australia, you actually need to see the decedent. Or you have considered the information about the deceased person's medical history, the circumstances around the death, and you are able to form an opinion as to the probable cause of death. So you don't have to be certain, you just have to have a degree of probability around what caused their death. So this applies to patients in the same GP setting. You haven't actually seen that patient, but you have access to the records and you can come to a possible cause of death summation. This is what an MCCD looks like. And death certification in the ACT is where a medical officer, so at this stage it's only doctors who can do this certificate, and it can only be done if it's not being referred to the coroner. So importantly, within the ACT, if we're involved, it's an additional filter by having my team involved. We're doing that scene examination, the ID is being confirmed by the police, and we have the coroner's team oversight of every death that we go to in the community. So there is a filter built in for GPs. So a doctor not responsible for the medical care of the deceased and who has not examined the body, you can still look at the person's medical records, speak to another doctor regarding the deceased, so that could be my team, and consider the information about that person. Then you can write the death certificate. So just to reassure the team that within the ACT, you can do these things without actually having seen the person. In practice, however, ideally it should be the treating doctor, and this is why my team don't do death certification, we just do the death verification. It could be another doctor at the same practice or the forensic pathologist. So key points with this one. So the MCCD does need to be completed within 48 hours after the death or knowledge thereof. And the death does not need to be reported to the coroner. You are comfortably satisfied as to the cause of death. So what does it actually mean, being comfortably satisfied? It essentially means more likely than not. So importantly, it is not the case that a doctor must be certain of the cause of death to be able to complete the certificate. So even forensic pathologists who do postmortems, do the histology, sometimes they are not certain 100% of the time either. So you don't need to be certain. So death verification, which is a very different process within the ACT, this is what our life extinct statement looks like. So it's very different to the MCCD. So it's a verification of death is a clinical or radiological assessment to establish that a patient has died. So within the ACT, it's in a paper form. So for my unit, this is what our form looks like. The AFP can also provide this form to GPs to fill in. And it's just the regular signs of death that you're verifying. So making sure there's no pulse, no heart sounds, no breath sounds, and there's fixed and dilated pupils. So once you're confirmed all of that, death verification can be done. Doesn't need to be done if the person's obviously decomposing though. So within the ACT, registered nurses may verify death, but not certify death. For patients they provide care to. And within the ACT, it's the ACT Palliative Care Service, it's hospital in the home, and patients receiving palliative care. So those provisions are in place for the RNs to complete these certificates, and also within these teams too. So finally, so you're not expected to be experts in death examination. Be aware of the Coroner's Act and when referral should be considered. And if you're not sure, you're more than welcome to call my team or the coroner's team, and I can assist with that. Death certification can seem tricky. However, it's purely the comfortably satisfied litmus test. And again, it essentially means more likely than not. It is not the case that a doctor must be certain of the cause of death to be able to do the certification. So finally, I just thought I'd diffuse that. So these are a couple of my other favorite characters when I go scuba diving. So in the top left-hand corner, we have a frogfish, really quite ugly, but cute at the same time. Also love moray eels. I got to see this guy in Indonesia recently, and then a stingray. So I hope I haven't talked at you. Sorry I can't see people and their reactions, and I hope that was helpful.
Thank you, Amanda. Thank you. Has anyone got any questions? Receiving claps, Amanda. Thank you.
Great. Okay, I'll stop sharing now and have a look.
Great. Thank
Oh,
you.
faces again. Amazing.
All right, thank you. So, excellent summary. Thanks, Peter is saying. Thank you. It's really good to have that background understanding. That's for sure. So just check one more time. No further questions. All right, so I'd like to introduce Dr. Lavinia Hallam, who is a jobbing pathologist with ACT pathology, and she has a special interest in paediatric and perinatal pathology, adult histopathology and forensic pathology. I have a question for you right from the start, Dr. Lavinia. What does jobbing pathologist mean? Thank you. Handing over to you. Thanks so much.
Thank you. It basically just means that I do the job all day, every day, and thoroughly enjoy pathology. It is the foundations of medicine. I think we're not teaching our juniors that so much as in my day, where it was forced down our throats that you had to know your physiology, your biochemistry, and your pathology. But yes, I do some urology at the moment, urology as in bladders and testes and prostates rather than the brain, because I find that those two terms are often confused because people don't quite hear what you're saying. But I've always worked on the principle that I enjoy pathology, and once I feel satisfied in one area, I may go on to another area and develop an interest in that. And that way you keep learning, which I think is important.
Lovely. Thank you very much. All right. So you've got your presentation up, but you need to swap screens, I think.
So let's try that. Has that done it? Has that done it?
Yes, it has. Perfect. Thank you.
Okay. So just to say that hopefully there won't be too much repetition in this, and that any repetition will be useful, because they say you only remember 25% of whatever you hear or see. And so hopefully if there is repetition, that will help increase that percentage. I'm going to talk to you about death certification. I've got investigation there, but it's mainly death certification in this talk. I don't have any conflicts of interest apart from the fact that I am OCD and I love pathology, and I do find that I tend to try and encourage everybody else to love pathology as well. So anyway, going to my first slide, this I think is useful to remember. you may be unsure of the cause of death when you're trying to write out a medical certificate of cause of death, but you are probably the one person most likely to have the best idea. And to go on from what Amanda was saying, that even if you have an autopsy, often we can tell you what somebody's died with. Telling you what somebody's died of is more difficult, and you have to assess the evidence and come up with what you consider is the most likely scenario. So going on to the next slide, I thought I'd just talk very briefly about why we certify death. It's the legal recognition of death. And you will fill out a form that's called the medical certificate of cause of death. The actual death certificate, the formal death certificate, is actually issued by the Registrar of Births, Marriages and Deaths. So your certificate will go to births, marriages and deaths, or hatches, matches and dispatches, as we used to call it. And they will then issue the formal certificate to the family. It is your authority, if you're the next of kin, to dispose of the body. And it is a requirement for many of the aspects of handling the deceased estate. So execution of the will, obtaining probate, talking to insurance companies, accessing bank accounts, closing your electricity and gas and water accounts, etc. So that's the legal aspect of why we certify death. In addition to this, the births, marriages and deaths will actually send the information on to the Bureau of Statistics. Now, why death? Basically, there are two sentinel events in life that none of us can escape. One is being born and the other one is dying. And so we get a broad overview of everyone, the whole of our population in Australia. Obviously, if you're living in a country like deepest Congo, you don't have that register of births, marriages and deaths, or whatever you call it in that country, or they may not collect the statistics as routinely or as consistently as in shall we say, the more affluent countries. That information can also be used for research. It can be used for the allocation of health funding. Interestingly, when I was training in Scotland, the government decided that it was going to put a large hospital for atherosclerosis and heart disease in the North England, Scotland. And they used the death information to decide that should go to Glasgow. Now, as it happens, that's probably a good thing, because if you've ever been to Glasgow, you know that they smoke, they drink, and they eat everything in batter. So you have your battered Mars bars and your battered haggis and all sorts battered pizzas. And so it's not surprising that they have a very high incidence of heart disease, etc. But in fact, if you actually looked at the way that deaths were certified in Glasgow, very often people would drop down dead, or they'd come into the public morgue. And if you didn't have a knife sticking out of your back, you actually just signed up as ischemic heart disease. So I think we can do a bit better than that, and that we can actually try and make sure that our death certification is as good as it can be. And hopefully that will mean that allocation of health funding will not be hit and miss, and sometimes going to the right place. It also enables us to have international comparisons, and it works both ways, so that we may be able to say, well, maternal deaths in, as I said, the back of beyond in Africa are unacceptably high, or it can tell us how well we are doing, or if we're not doing as well as our neighbours of a similar wealth country. It's also useful for the family. It gives them the cause of death, and this can often provide closure. And I think that's something that we don't really think about so much. And in some circumstances, it may highlight relevant medical history for other members of the family. A very good one here is young people who die suddenly. Then the cause of death may well go to the coroner because they'll need to have an autopsy. And if you have a negative autopsy, then this is likely to be an arrhythmia, and many of the arrhythmias have an inherited aspect to them, and so that the other members of the family can be consulted, they can be counselled, and they may be referred on for investigation with an idea that we may be able to prevent some other deaths in the family if it's an inherited condition. So going to the next slide. As I said, death is a sentinel event. No one escapes. Why collect the death data? As I said, at the local level, at your hospital level. It can be used for quality assurance and audit in the hospitals. We have mortality reviews. There may be service level audit. We've got clinical review committees, hospital level audit, hospital level investigations. Patients may or may not die in hospital, so that if you've got patients that are regular visitors, then the unit may want to know what the cause of death is, and to have a good think about whether they were providing the appropriate care. As I said, research on the national and international level. And then, of course, we have specific databases and reviews. We have perinatal, infant and childhood deaths. These shouldn't happen, one would say, although they do. And if they do, we want to know why, and are there any things we can do to prevent them. Similarly with maternal deaths, and in the hospital setting, things like anaesthetic deaths and surgical disasters or medical disasters. The death certification is governed by births, deaths and marriages registration in the ACT. Following a death, we have the confirmation or the verification of death, as we've heard. There's the consideration for a coronial referral, in which case we're all let off the hook because the coroner issues the death certificate, having done an investigation at various levels. So as Amanda described, this may just be a round table discussion through to a full police investigation with an autopsy. For the non-coronial deaths, a medical practitioner will issue a medical certificate of cause of death, and they'll do that if the death does not need to be reported to the coroner. However, you can always discuss with either Amanda's team or with the coroner's officer if you're unsure. They are very happy that, you know, for you to contact them and to discuss it, presuming they haven't had a very bad day. And it can give you the confidence that you don't need to refer, or that you know you can go ahead and do this medical certificate of cause of death. You can sign it if you are, as Amanda has said, comfortably satisfied that is more likely than not as to the cause of death. As I said before, even with an autopsy, we can tell you what somebody's died with, but trying to tell you what they died of can be a little harder. As Amanda said, no requirement in ACT and Queensland to view the body prior to writing the certificate, and it should ideally be completed within 48 hours of death. Then the family, you give the certificate to the family or the undertakers, and that is then registered with the births, deaths and marriages, and then they can issue a formal death certificate. If it's referral of a death to the coroner, I think this is simplified, but it perhaps is easier to remember. If the identity of the deceased is not known, then that certainly has to go to the coroner, and the identity has to be established. Or if it's not established, then usually you have to know the coroner will keep the body. If after a few years it's decided that it needs to be interred, then the coroner can issue a directive to inter the deceased. It's not usually cremated, it's usually a burial. And should somebody come forward in the future, then there should be a track of what happened to that body, and so that the family, when they're found, can have closure and know where their deceased is, or have some say in how the deceased's body is dealt with. I don't think many people actually ask for an exhumation, but I presume that is possible as well. If the cause of death is unknown or unexpected, or if the deceased has never been seen by a doctor or a healthcare system. If the death is unnatural, and basically we're thinking there of accidental suicide and homicide, it can be, as I'll show later, a little difficult sometimes to decide whether it's an accident or a suicide or a homicide. If it's a result of a medical mishap, and here we've got anesthesia, surgery, drug problems, if somebody's been given the wrong drug, too much of the drug, or if there's been a diagnostic procedure and maybe the patient's exsanguinated because a vessel's been pranged, or so, anything like that. So any medical mishap should be referred to the coroner. It used to be that if they'd had any medical procedure within 72 hours of that, if they died within 72 hours, then that went to the coroner. But again, the coroner may not take the case. You know, it's up to the coroner. He'll discuss it with the medical staff. And if he's happy that it doesn't have to come to him or her, then they can say, no, that's okay. The other one to remember is any death in custody has to go to the coroner. And this is not just police custody, but if you're sectioned under the Mental Health Act, or if you're if you're in care for any other reason, then that's classed as in custody. It's not in police custody, but it is in custody of the state. So I think that's perhaps a little, that's simplified, but I think it helps better give you the idea of the role of the coroner and which deaths should be referred. As far as death certification, I like this because this is what I used to tell the junior doctors in the hospital. Medical practitioners have a professional responsibility to ensure accurate completion of death certificates. But that's not to say it's always easy, because it's not. However, it is beholden on us to do our best. And as we've said, you know, you'll probably, if you know the patient, you're the best person to make that assessment. And we want to make that assessment. And that without the proper and timely documentation, the body, as Amanda said, the body can't be released, funerals may be delayed. And in the hospital, as I used to say to our junior doctors, you will not be popular if you don't do the death certification in a timely manner. I do think on this aspect that we aren't training our junior doctors properly. Death certification is often left to the most junior doctor. That's unacceptable. Like autopsy consents, it should really be done by the senior doctors, who should, when they're doing it, teach the juniors. I certainly, when my husband died, I took both my children and we did everything together, organising the funeral, etc., etc. And some people said, well, why are you doing that? And I said, because when they have to do it for me, I don't want them flaying, you know, they're going to be upset, hopefully, but I want them to know what is involved and what, you know, they need to do. And I think that for death certification, seniors should be teaching the juniors so that they know exactly what they should be doing and how they should be doing it. We have just coming to the death certificates. What you will have to fill out will be the medical certificate of cause of death, which is the one on the left. I probably should be pointing this way. The one on the left. The one on the right is the other medical certificate of cause of death that's used, and that is the perinatal death. And so any stillbirth greater than 20 weeks through to the first month of life, you will fill out a medical certificate of cause of perinatal death. Now, most GPs, unless they do some obstetric deliveries, won't ever come across that certificate. Post-neonatal death, which is anyone over a month of age, you have to fill out the medical certificate of cause of death, which is the one on the left. So the principles of death certification, what we need on these certificates, what the Registrar of Birth, Marriages and Deaths needs is to know who was the deceased. Often you'll be asked for the age, but not necessarily the date of birth. More and more, I think the date of birth is becoming mandatory. And for somebody who does some genealogy, the date of birth is a godsend. But I'm not sure that's top of the list of reasons for adding the date of birth as well as the age for the Registrar of Births, Deaths and Marriages. You want to know where they died, and you certainly want an estimate of the time of death. And that is important because if you're found, say, deceased and nobody's found you for 3 weeks and your insurance ticked over yesterday, if you can say, well, you know, the body's mummified, etc., it's weeks, the death has been occurred several weeks ago, then the insurance company can't say, oh, well, we can't pay out because we don't know when the deceased died. They may have died after the life insurance finished. And then the 3 things that I'm going to talk about briefly are how we describe deaths. One is the mode of death. That's the way the death occurred. And this really, as I'll show in the moment, is not a cause of death. It's how the death came about, the way the death came about. So exsanguination, respiratory failure, cardiorespiratory arrest. They're not causes of death. They're just modes of death. It tells you how the death occurred. Can be useful because if you are doing forensic pathology, for instance, and you're told that the deceased dropped dead in the street, that will give you some idea as to what you might expect. Is this a stroke? Is it a heart attack? Has there been an aortic dissection? All of these things, you know, you'd think about if the patient had been in a coma for days, that implies that, you know, they'd been under medical care, and maybe this was palliative care in a cancer patient. The cause of death is why the deceased died. That is the most important for all the statistics, for all the legalities. And then the manner of death, how the death occurred, that's really the province of the coroner. They will usually decide the manner of the death, and that would be, for instance, accident or homicide or a natural death. Right, I think we've gone through most of that, so you'll have it on the presentation. I have sent a PDF to Ros so she can send it on. So as we talked about, post-perinatal death, medical certificate of cause of death is the one you'll fill out. Perinatal death, stillbirth less than 20 weeks to the end of the neonatal period, which is 4 weeks. That's the medical certificate of cause of perinatal death. And the reason we separate them out is because the perinatal deaths, you've got two aspects to that. One is the actual baby. The other one is what happened during the pregnancy and the effect of any pregnancy complications. And in some jurisdictions, as Amanda said, can be completed by a nurse or midwife, but not the ACT. You'll also have cremation forms, and so this is usually a second form if the family want to have the body cremated. It's a second doctor form that you have to sign. Dreadfully, I know, but we used to call it ash cash because the second doctor got a payment for filling out the form. I don't know what happens here, whether there's a payment or not, because I never liked filling them out. And if I did fill them out, I never took the money. But I presume that the undertaker who we liaised with probably pocketed it, unless they were really, honest and gave it back to the families. If you are wanting a non-coronial autopsy, then that's another form you might come across. That's the request form. And if bodies have to be repatriated abroad, then that's yet another form. But for all intents and purposes, it's just the first form that the medical certificate of cause of death that you'll probably be involved in filling out. Going back to what I was talking about, the mode, the cause, and the manner of death. The mode is the mechanism. It's not a cause of death, as I said before. It's the process by which death occurred. As I said, cardiorespiratory arrest, etc. It can only be listed in 1A, and it must be followed by a cause of death in 1B or 1C, depending on whether you put an interim cause of death in 1B. So you can't just put cardiorespiratory arrest. You must put a reason why the patient suffered a cardiorespiratory arrest. The cause of death is the disease, injury, or combination of conditions that leads to the death of the individual. Now, you can put more than one, with the death certificate, you have 1A, 1B, and 1C. You can put the cause of death in 1C. Having put in 1A and 1B, you might put mode of death in 1A, an interim process in 1B, and then the cause of death in 1C. Whatever you do, or you might just have a mode of death and then put the cause of death in 1B. But whatever happens, the cause of death must be the last one, because that's the one that the registrar of births, marriages, and deaths will use as the cause of death. And it will also be the cause of death used in statistics, etc. If there are conflicting or multifactorial causes of death, then you have to make a decision as to which you think is the most important and that precipitated the events that led to the death. And again, the first thing that caused all of this sequence must be listed last. Comorbidities not related to the precipitating event are listed in 2. And this can include risk factors, e.g. smoking, alcohol use, etc. So going in summary, this is the medical certificate of cause of death on the left. You can see there that have part 1, and then it goes A, B, C, D, and E even in this. Doesn't matter how many of these that you fill in, but they must be in sequential chronological order, with the cause of death being the final line. So if you want to put the cause of death in 1A, you can, and then you have to say approximate interval. And that's useful because if you're filling out more than one of these lines, if you're forced to say, well, say you're putting a mode of death and you put cardiorespiratory arrest and you put down the time as minutes, and then you want to put ischemic heart disease, you have to say that, for years. So it helps you to list them in the right order if you put those timings down. So 1A, immediate cause, may be a mode if you want to put an immediate cause. 1B, intermediate, intervening causes. 1C, as we said before, underlying cause. You can have 1A, 1B, 1C, 1D, 1E, and you could even do more if you really wanted to. But my advice is keep it simple. And I often just put the two down. As I said, you can go straight for the jugular and just put the cause of death in 1A, or a mode of death in 1A and a cause of death in 1B. And then, as we said, 2 down here, part 2, is where you put those things that you feel really didn't help the patient and will have contributed to his death, but is not directly related to what you have decided is the most likely cause of death. As I said, requirement to estimate the duration for each. I think it's a good aide-memoire to making sure you get the sequence right. And so the duration of 1A cannot be longer than 1B, and neither can be longer than 1C, etc., etc. We've done that. Other significant conditions, any pre-existing or coexisting condition that contributes to death but did not result in the underlying, did not result from the underlying cause of death, or did either result in or from the underlying cause of death. And it, as I said before, may include risk factors. People forget about that. That means that the statistics on tobacco and alcohol is not necessarily as good as they could be. The manner of death is different. This is the province of the coroner. We don't have to decide about the manner of death. This is the classification based on how the cause of death was brought into play. It can be natural. If you don't know what the cause of death, somebody's died suddenly, goes to autopsy, there's a aortic dissection, that's still a natural death, even though it's gone to the coroner, and the coroner can rule that as a natural death. It can be an accident, a suicide, or homicide. There are the 4 basic ones that manners of death. Obviously, even the coroner may not be able to determine the manner of death, or the manner of death you may have 2 or 3. You might be unable to say whether it's an accident or suicide. In a motor vehicle accident, did the deceased drive purposely in the wall, or did the wall jump out in front of the deceased, sort of thing. As I said, province of the coroner, don't have to worry about it, except it's quite useful to understand what it is. So just a couple of cases to hopefully help that what I've said become a bit clearer. 75-year-old male smoker, 5-year history of emphysema, admitted for exacerbation of his lung disease, and he was found to grow Haemophilus influenzae and had Haemophilus pneumonia. He had other medical problems, coronary artery disease of 10 years duration. 1 week later, he's found deceased in bed, and you have to pronounce and certify death. So you can see why, from that sort of history, why the GP or the medical person who's been looking after the patient in hospital are the best people to decide this, even though you may, just like any pathologist, you may know what the patient has died with, not of. You're probably still the best person to make that decision. So, do we certify it as respiratory failure in 1A? And we'll put his ischemic heart disease as contributing in 2. This is incorrect. And the reason it's incorrect is respiratory failure is a mode of death, and you're not putting anything after it. So you're not effectively giving a cause of death. And correctly putting coronary artery disease as a contributing factor. So maybe we should put emphysema and pneumonia. Certainly he came in with the pneumonia, he's had emphysema, and as we said before, coronary artery disease sits nicely in the contributing factors. However, if you were to if you were to put how long each of these had occurred for, the pneumonia might be weeks or days. Emphysema is longer. It's 5 years, we said in the history. So this is the wrong order. So this is improper sequencing. So you can put pneumonia and 1A and emphysema 1B. That's proper sequencing. And you can see how, if you were to put, as you should do on the death certificate, the time frames, that helps you to make sure you put them in the right order. Or that's what I find when I was filling them out. We used to, although the coroner decided the cause of death, we often said, our opinion is this is the cause of death. You could, in this one, you've got emphysema as 1A, 1B as coronary artery disease. This is incorrect. A, coronary artery disease does not cause emphysema, and that is incorrect. And we're giving, in those circumstances, competing causes of death. What will go down in the death certificate is coronary artery disease. Whereas, in fact, I think I would feel that emphysema was more appropriate. So, shall we see what we can make more perfect, if not perfect? So 1A, Haemophilus influenzae pneumonia. You might have a week or 2 weeks. Emphysema, 5 years. That all fits. That's beautiful, perfect. Coronary artery disease in 2 is a contributing disease. And then I've added smoking because it's one of the things, even though I'm an ex-smoker, I didn't smoke for long, but I did smoke sometime in my life when I was a student. I do feel that we should still be recognizing that it's a big risk factor. And so, as I said before, if this was a coronial certification, then they would also record the manner of death. And that would be natural in such a case if this person had had an autopsy and it was the pathologist doing the death certificate. Case 2, 29-year-old man. These two are just do very quickly because it's more about giving you an understanding of manner of death. 29-year-old, previously fit and physically well, episode of depression several years ago, found deceased in his car that had ploughed into a brick wall after failing to negotiate a bend in the road. Autopsy findings. This was a coronial case with an autopsy, multiple injuries, multiple skull fractures, hemopericardium, ruptured aorta, multiple hepatic lacerations, and a blood alcohol as there. So what you might decide is exsanguination due to multiple injuries and a motor vehicle accident. So you're not actually listing all the injuries, although the ruptured aorta is probably the most important there, leading to the exsanguination. But the manner of death could be accidental or it could be suicide. And so it's then up to the coroner, that's their job, to look at all the information and decide and they can't be sure, just like you writing the death certificates, you can never be 100% sure, but they will then make a considered decision as to whether they think this is accidental or suicide. 37-year-old man, known drug courier, found dead in alleyway with gunshot wound to the head. Autopsy findings, we've got the gunshot, bags of cocaine in the stomach, high level of cocaine in the blood. So you might say you've got two good causes for a cause of death. The gunshot wound won't have done him any good, and neither would the high level of cocaine, so cocaine poisoning. You do occasionally in the coronial setting, you might put both. You can't put them sequentially because they're not necessarily sequential. Well, they're not sequential, but the manner of death could be homicide. He could have been shot by another drug gang member. He could have accidentally tripped on a gun or something, or he could have decided to end it all. So that just gives you a bit of an illustration of what the coroner's role in establishing that other aspect of death certification, the manner of death. But as I said before, that's not your province. And unless, of course, in the sense that if you have concerns that this might be a homicide or an accidental or a suicide or what have you in any death, then you can always raise that with the coroner. And if you are seriously concerned, then obviously you should raise it with the coroner and not do the death certification. I thought, just as an aside, in the last 10 minutes, I'd talk about some of the recent developments in death certification in the UK, because it is quite interesting and it may actually end up coming here. I haven't heard any rumours about it, but I think it does, what they've introduced now in the UK, I think it does have some value. So it all arose basically because of Harold Shipman, whom we all know. He was found guilty. That was me to find out the date, and I never did. So sorry about that. He was found guilty of a total of 250, the inquiry looked at a total of 250 deaths that he'd certified, and they found that 218 were unlawful killing and 32 were highly suspicious of unlawful killing. Now, he got away with it for years and years. He was injecting his patients with opiates on the whole. Some of his hospital deaths may have been potassium chloride. Dreadful man. And it was a shock to everyone, because until that time, nobody believed that a GP would kill their patients. He had a life sentence. He was incarcerated in Wakeham jail, and he committed suicide by hanging, probably just before his wife, who he seemed to be quite fond of, Prudence, was due to get her pension. And I think he felt that if he committed suicide, they couldn't argue as to whether she should receive that pension or not. But really, who knows? It may just have been part of his control behaviour. So, in addition, he killed 15 as a junior doctor in a hospital. And that was 30 years prior to when he was caught for the other deaths in Hyde. And it showed that his spree of murdering was over a long period. They occurred, the 15 that he killed as a junior doctor occurred between 1971 and 74 at Pontefract General Infirmary in West Yorkshire. And it was the sixth report of the Shipman inquiry that looked into these deaths to see if there was good evidence that he had actually killed these patients. So what they did was to review the Shipman death certificates. So they got all his death certificates from that period. And their conclusions were that a high number of deaths that occurred on the medical wards during this period were certified by Shipman while working on those wards. The difference in the causes of deaths between what Shipman recorded as causes of deaths and other doctors recorded as deaths was a high number of cardiovascular and cerebrovascular causes. So he was writing them up as strokes and heart attacks. He was more often present at the death, which was quite suspicious. The deaths occurred in the evenings, which is when, if you look at the normal range of death certification, for some reason, deaths don't occur in the middle of the night and they don't occur in the evenings. Who knows why? But if you looked at other doctors certifying deaths, their deaths occurred at different times of the day. As I say, he was more likely to be at the death of his patients than his colleagues. These were this was the review of cremation forms as well. And with these, Shipman was more likely to be at the death of his patients and colleagues. He was likely to see the body sooner after death, which suggested maybe that he was loitering around at the nurse's station, waiting to pounce, who knows. His patients appear to have died more quickly than those of his colleagues. So again, when we're talking about the mode of death, exhaustion, coma, his appeared to be quite well or not expected to die and then died while he was on the ward. And as I said, the distribution of times of death of his patients was unusual and occurred at different times of the day to his colleagues. And all of this was thought to suggest that maybe he had been unlawfully killing them even this early in his career as a house officer and a junior doctor. So because of these concerns, as you can imagine, there was a working party to look at the reform of the coronial system. It was also brought about by the Bristol and Alderhay inquiries. The Bristol inquiry was because there were increased deaths in paediatric cardiac malformation surgery at Bristol, and in Alderhay because during the inquiry in Bristol it came to light that there were collections of hearts, and one of those collections was in Alderhay. And all of this really undermined the confidence of the public in the coronial system and in the death certification by doctors. Shipman, he failed to report the deaths to the coroner. So one of the things that happened was that the president of the Royal College, the Royal College of Pathologists, was rung up when all of this was occurring, and pathologists were getting a bad review at the time. And it was somebody from the press wanting to know why the pathologists hadn't identified this issue earlier. And the first thing he thought was, oh no, not the pathologists again. But in fact, when he thought about it, there weren't any autopsies, so it had nothing to do with the pathologists not finding, not identifying an issue, because he used to purposely, he'd say, I can sign the cause of death, this is Shipman, and he'd persuade relatives and staff that referral to the coroner was not required. The other thing was the ignorance ignorance is perhaps not the right word, but the faith of the public in doctors, and the police didn't take concerns that were being expressed by a nearby practice that his deaths were unusual. They were being asked to sign creme forms for those patients, and they thought, oh, he's got more deaths than we had by far, all of us put together. And then what is the province of the pathologist was that the poor quality of coronial autopsies, and that investigation of deaths is probably not thorough enough because it's under-resourced and lack of expertise. So they had a fundamental review of death certification and investigation. They've undergone a reform of the death and cremation certification and reform of the coronial system. So death certification investigation in England and Wales and Northern Ireland. It's a review of 2003. It's taken a long time. It's only recently, I would think over the last 5 years, 6 years, that the system's been up and running. There was the introduction of Advisory Coronial Council to advise on policy, a chief coroner for the whole of the 3 countries was appointed, and they were accountable to government. There was a chief medical advisor, so the coroner tended to be legally qualified. He then worked in conjunction with the chief medical advisor, and then they introduced local coroners or medical examiners, they're called. So these are not the same as the medical examiners in the States, which are actually pathologists and coroners. So they do both roles. They do the coronial autopsy and the coroner's function as well. They'll decide the much broader investigation than pathologists do, more along the line of the coroner. So the local coroners or medical examiners are supported by the coroner's officers, and what they basically did was, if we go up here, is they introduced a system that there are 2 certifiers for every non-coronial death. So there was the system that went to the true coroners, and then we introduced this medical coronial medical certifier, who's also known as a medical examiner in the UK, and not in Scotland but elsewhere. So we got rid of the creme form, and for the creme forms you'd have basically two people to overlook the death and to check that there was nothing untoward. It wasn't done very well, and as I say, it was seen by some people as ash cash and a form of revenue, which I don't think you should ever do, because that just complicates things. That's the red in the bed in me coming out. So they got rid of the creme and they'd only have two people look at the deaths if there was a cremation. They've got rid of that. There are now 2 certifiers for every non-coronial death. The deceased medical practitioner, who's called the first certifier, and the coronial medical certifier, who's called a medical examiner. And they're the second certifier. And I think that's probably a very good system. And both can support the other, that both talk to each other. The medical examiner can talk to other people, can talk to the family, see if there are any concerns that they have, and then they can decide. I've put that, this was when it was a draft, but it's actually it's in law now. So the algorithm now for deaths in the UK, the death certificate is filled in. This is the medical certificate of cause of death, not the death certificate as such, by the attending doctor. if seen within 17 days. I think that's changed a bit. The certificate and documentation is forwarded to the medical examiner, not the coroner. That's changed. And then the medical examiner looks at all the information. If they want more information, they can talk to the family, they can talk to other doctors, etc. If it passes the review, the certificate is issued. If it passes straight away, it's quite happy that everything's in order. Certificate issued. If it passes review after a preliminary investigation, certificate issued. If the medical examiner decides this needs to go for the coroner, they can refer it to the coroner with or without recommendation for autopsy, and then the coronial investigation takes over. I think it's quite a good system. The issue that they have had is getting people trained up to the medical examiner role. And it does take a good 6 months, and it's quite strenuous training. There's quite a few documents. I looked at it, and you have to look at 60 documents, and then you have to go for a face-to-face session, and then you have that's in your first 6 months. And then after that, in the next 18 months, 2 years, you have to look at a whole lot more documents. So I think they've had a bit of trouble getting people into the system. But I think that people who have done it most of them believe that it's probably a good system. So just in summary, because I'm 5 minutes over, remember, medical practitioners have a professional responsibility to ensure accurate completion of death certificates. That doesn't mean you have to know 100%, because none of us know. Even if we've had an autopsy, we don't know. We just know what people have died with. I think the person that is most appropriate to do this is the person closest to the deceased, because they stand more chance of knowing the person. You'll issue a medical certificate of cause of death. If the death does not need to be reported to the coroner, we've talked about which one should and shouldn't, and you are comfortably satisfied, i.e. more likely than not, as to the cause of death. You don't have to do it on your own. You can always discuss it with your colleagues, with the patient's doctor at the hospital. There are various documents that you can refer to, colleagues, other professionals, medical defence organisations. They all have crib sheets and pamphlets on how to do it. The WHO and the government has documentation how to do it, all aimed at making sure that we get the best information. It's in all our interests to get the best information, but everybody understands that it can be difficult. Hopefully this talk will help you out understanding the documentation and the rules that help you to ensure to fill out the documentation correctly. So I'm happy to answer any questions. I hope it hasn't been too boring.
Thanks so much, Dr. Lavinia. Any questions for Dr. Lavinia? Getting some claps. Thank you. Any questions? Some claps? Comments? Let me just check again. The one question from me is the unclassified deaths in the cause of deaths that you showed the pie chart, the unclassified deaths. What are they? Because
I think that was under the manner of death.
Yes.
And so what would be an unclassified death would be one where the coroner, just bear with me, I'll see if I can find where it is. Be better that way, won't it? Just let me get the pie. So the
undetermined deaths, I think.
Yeah, that will be one where there's insufficient information, or where the coroner absolutely feels he can't decide whether it's it's a suicide or a homicide. So it's the catch-all for those where you're not sure, and again illustrates that nothing is cut and dry and 100% certain. Life is not 100% certain, is it? So the undetermined might be like I discussed in the manner of deaths. Those ones where could it be a homicide, could it be a suicide, if your investigation doesn't enable you to. The car accident, I think, is the classic, isn't it? Did he run into the wall, or did he or was it an accident that he went into the wall? So that might well be an undetermined, but as you can see, it's only 3%. So like everything in life, we try and keep undetermined as small as possible. But it does, all of these things are goalposts. When I make a decision about a biopsy, I quite often have goalposts. And when you're at the edge of the goalpost, you think, for instance, if you've got a bladder cancer, is this a high-grade bladder cancer? Is this a low-grade bladder cancer? And you make the best decision that you can. And, you can't guarantee that you've made the right one. Nobody can. It's just an opinion. But if you go into it giving an opinion to the best of your ability, then that's going to give the best information. If the person closest to anything gives the opinion, for instance, for us with pathology, when we're staging, we can give all the information to the clinicians and say, there we are, you go away and stage it. But we're the ones looking at down the microscope. We're the ones closest to the slides, and we're the ones that are best able to make that decision in most cases.
Great. Thank you. No other questions? Matthew says very helpful. Thank you. And thank you. And this presentation will be recorded on the CHN, held on the CHN YouTube channel. So for those that couldn't attend tonight, Dr. Lavinia, you mentioned that you were going to send the PDF of your presentation. Amanda,
I think I sent it to you, but if I haven't sent it to you, it was because I meant to and I've pressed the wrong button. So just let me know. So I've just PDF'd it, and if you want to distribute it, you're very happy. I'm very happy. There's nothing there that.
Great. Amanda.
Yes, I can do the same, Ros.
Okay, lovely. Thanks so much, everyone. Have a great evening. Enjoy the little cold spell before the hot weather comes back. Take care, everyone, and we'll see you next week for our final session, which will be reflecting on how voluntary assisted dying impacted health professionals in other health jurisdictions around Australia. Thanks very much. Take care. See you next week. Okay, bye-bye.
Thank you for inviting me.